big flopping differences, by the way, with these two populations. So we replicated the study. If you don't like it, we went to the ECA, and this is whites within the epidemiological catchment area of the Baltimore study. Exactly the same effect. If you engage these behaviors combined with the stress, higher probability of being the case. If you're black, on the other hand, it's just the opposite. If you don't do it, then you're more likely to be the case than if you do it. And if you don't like that, we replicated it again within the NESAR. This is one of the studies, Keys et al. Actually reported that they couldn't find this. They made a little mistake with regard to the construction of the stressors. We reanalyzed the data with a better measure of the stress, and what we find within this study now is exactly the same thing we would find with the other studies. For whites, not much of an effect, all right, but in the trend, where engaged in behaviors with stress makes you more likely, but for African Americans, just the opposite. And this is a significant effect. So for African Americans, so 3 different studies, 3 different data sets over a period of about 30 years, and exactly the same effect. So blacks have early learned environmentally mediated effective coping strategies to deal with stressful conditions of life. This is very important. These behaviors are not merely a diet, which most people complain. Straighten up. Stop eating so much. Straighten up. Stop drinking. Straighten up. Stop smoking. And why do people tell you that? Because you chose to engage in those kinds of behaviors. And if you chose to engage in those behaviors, you can choose not to engage in those behaviors. These are hedonic decisions that you make. We argue they're not hedonic at all. They are adaptive. And people engage in these to reduce this activation in the chronic stress response network, and they're rewarding for individuals. And not only that, these behaviors are of habit forming. Smoking, drinking, overeating. So you begin to run into problems with a totally different reward system that relates to drug use and other kinds of issues. So you have 2 reward systems that are operating. One reward system reduces the symptoms of these bad, stressful events. The second reward system are the rewards that you get from addictive kinds of behaviors. Second, these behaviors are affected, we believe, through this chronic stress response network. And they contribute along with poor living conditions, lack of resources, environmentally produced chronic stress, to produce the race disparities in physical health, morbidity, and mortality that we observe. That's our argument. So, things that are effective for African Americans in preserving African American health may simultaneously contribute, along with bad living conditions, to indeed produce the observed differences in mortality and morbidity. So we argue, succinctly, blacks and other groups in society may buy their reduced rates of psychiatric disorders, with much higher rates of physical health morbidities and access and early mortality. It's a trade-off. So, people don't like that. People don't like that for a whole bunch of different reasons. But the data, I think, are very clear and compelling. What they don't like about it, James, are you arguing that there's a biological mechanism which produces this? Is the biology different for blacks and whites? That's the question I get all the time. So I asked that question before you answered. So, our argument is that there are conditions when the complex contexts of life masquerade as racial differences. And we're off into a whole other area of research now. And we're arguing that what seems to be race differences in a lot of areas have to do with regard to the composition of the populations that produce those particular differences, and they got no more to do with regard to race and what your race is than the man and the woman. And so what we need to do is find out what those compositional issues are. Race is not a variable. We can't assign race and then take it away and give it to somebody else and whatever. It's not a variable. Second of all, race is a very complex construct that in adulthood captures a wide set of life experiences that people have. We argue that individuals in this particular society, and there's some support for this, become black as they traverse life. The African Americans in society do not start off black, but they end up black. And it's this racialization that takes place within society that produces what you think are race differences. The category of race which is assigned you at birth bears little or no relationship to the category of race that you die in. And it has to regard to your particular experiences. And we're off and running on this particular work, and believe it or not, we're finding quite a bit of support, even in the literature, for this particular notion of how racialization might work. But we also argue, not to give it away, we also argue that there are whites in this society who become black. And the argument then takes you to a natural conclusion. If whites become black in this society for the experiences they have, then at the end of life, they should look like the blacks who've been racialized to be black. And that's exactly the research that we're now off on and running, and I'm going to share some of the research with you. So there are biological and social issues we should think about all the time. You know, there's this thing that what we do is we take all the black people in this room and we put them over here. We take all the people who are non-Hispanic whites, put them over there. The people that we assign to that black category are going to live 49 years shorter than the people that we put over in the white. And so the question is, what is your identity got to do with regard to dying 7 years shorter than somebody else who has another identity? Because if it's about your identity, there's a real simple solution to the problem of disparity. Black people need to stop calling themselves black. Now on, basically. 5 minutes ago I was black. Now I'm white. Whenever somebody asks me a question, I'm white. I'm going to live 7 years longer. It's just as silly, though. I mean, the way in which we do this, and why is that, and what goes on. And that's because the real issue is that having the categorization of black in society exposes you to all kinds of stressors that if you had the label of white in society, you would not be exposed to. So this supports the notion which I'm trying to make. Now there are some cases where race differences really matter. This is the stereotype front of it. What you see under a diagnostic test, if you're stereotyped as black, then your performance is not very good. If you're not in a diagnostic situation, your performance is equal to non-Hispanic. This is where race matters. Race has an effect. If you look at perceived major discrimination, you see huge racial differences in society, which are really race differences. Blacks and actually Afro-Caribbeans report much more discrimination than do non-Hispanic whites, whether 12 months or whatever the case may be, or whether everyday discrimination. All right, these are real race differences. But why do you get race differences in complex physical and psychiatric health? Why should we? In fact, there are a lot of people who argue that racial differences, as determined by skin tone and other things, are the last thing in the human genome that actually evolved. And why should that then be related to something that has to do with regard to complex diseases? So remember the point about being racialized over the life course, and what do you get? So we're using propensity analysis. Let me quickly do this. We're using propensity score analysis to explore the idea. That is what we're doing. Let me just be simple. We're making black people white, and we're making white people black. Statistically. And if you do that, you get very interesting kinds of effects. So remember what we get with regard to whites. If you engage in lots of bad behaviors under stress, you're more likely to be a case. If you look at the lowest quintile in the propensity of being black for whites, you actually get an increase. So these are people who are more white than white. the effect increases. It gets larger. If you look at the propensity of being black for whites, what you find is indeed a reversal. And it looks more like what we got originally for blacks. So this is under conditions of whites who have the highest propensity of being black. That is, they look black based upon the 14 predictors that we use to give them. So this is the same thing with regard to blacks. So this is what we find for blacks. And this is, if you're really black, you're blacker than black. This is a little joke we make. Then you're really, the effect is exaggerated. On the other hand, if the lowest propensity of being black, you're more likely to be white, the effect actually goes away and there's no differences with regard to the behavior. The second way we've done this is below the median. Irregardless of whether you're black or white, what we look at are people who are below the median. So they're less likely to be black, no matter whether you're black or white, and you get a clear effect. All right? These are people who are below the median on the propensity of being black. They're more likely to be whites. The effect looks just like what we got before for whites. But this is both blacks and whites, and they're above the median for the propensity of being black. Then indeed, you get the same effect that we got before with regard to black. No bad behaviors, more likely to come up with this. So what this shows, this effect is not a racial effect. It has to do with regard to what's with race. So you've got to have a bioecological model that emphasizes this. And we're doing lots of other research, but I won't have time to talk about it, and I won't, because I've taken all my time talking about this. But these are all research which have been derived from predictions. Just to mention the first one. We're doing a study which predicts, based on this model, that if you have a serious heart attack recommended for cardiac rehab, if you do what the physician says and you live under high stress, you're more likely to become a case of major depression by the end of the year. And it's a reason why people don't do what the physician says. And we're doing the same study with regard to type 2 diabetes. Derived predictions from the model. So, it's hard to understand these things, and we need new biobehavioral models. We need to focus on heterogeneity. The explicit assumption of homogeneity among groups is no longer tenable. And we need lots more research. Human agency, individual motivation, individual behavior must be considered in any theoretical formulation related to explaining population. Thank you.